I'm Sister Diedericks. I'm the transplant coordinator at Fortescue Hospital. And I was actually asked to speak about management of thrombocytopenia. And I was just thinking, let us just step back and basically first start by just explaining what basically thrombocytopenia is. And then we can go to the management of thrombocytopenia. So I'm based at Fortescue Hospital in Cape Town, and we are obviously a transplant facility at Fortescue Hospital. So basically, I'm just going to first do an overview of what I'm going to discuss. So basically, what is thrombocytopenia? Early symptoms, severe symptoms, the causes of thrombocytopenia, the diagnosis, how do they diagnose thrombocytopenia, and what is basically normal platelet levels to severe platelet levels that is causing thrombocytopenia. Then I'm going to do an overview of the management in acute phases and severe phases as well. And that because we are in a nursing setting, it's nurses training, I felt that I should include nursing intervention, self-care of the patients, and then I will conclude. So basically what thrombocytopenia is basically low platelet count in a patient. So basically the bone marrow is not making enough platelets. That is why the platelets are low and we call it thrombocytopenia. So what happens when we have a low platelet? So platelets are also called thrombocytes. Okay. So when the bone marrow is not making enough platelets, that means that your blood don't clot and you can bleed a lot, and it's difficult to actually stop the bleeding. Then I was thinking about early symptoms of thrombocytopenia to look out, especially for our patients, because it's very important to do a thorough, the questions that you ask the patient regarding their bleeding episode is very important. So then you can actually decide is the severe or acute phase or early phase. So excessive bruising, which also called purpura, is when they bump against any furniture or anything, playing a sport, they bruise easily. That can give an indication that the platelets are low. The red spot, they call it the red cherry spots on their body is also an indication that that there is low platelets. Very common is prolonged bleeding from the gums or cuts. Nosebleeds is very common, and heavy menstrual bleeding. That is more early symptoms, and then when you get to more severe symptoms, you will think about, go back one step, more severe is blood in the urine, when they vomit blood, headaches, this is more severe symptoms. Okay? When you have headaches, a patient that has thrombocytopenia, especially if they have headaches, blurred vision, dizziness, confused, pain in the joints, fatigue, enlarged spleen. These are all severe symptoms when it comes to thrombocytopenia. So I've just explained now the symptoms. So it's very important to know what can cause these symptoms, obviously. So what happens? Sometimes you have platelets and it gets trapped in the spleen, and then the platelets don't circulate in your body. This is where the low platelets come from, because the spleen is trapping all the platelets. When patients have cancer conditions like leukemia or lymphoma, it damages the bone marrow, so the bone marrow doesn't make enough platelets. Patients that have stem cell transplant always also can have thrombocytopenia. Other cases is like the bone marrow makes enough platelets, but the patients have a condition that allows the condition to use up a lot of platelets. Like your disseminated intravascular coagulation is a very good example where there's a lot of platelets, but it gets used up very quickly. Autoimmune diseases like ITP, which is also called your immunothrombocytopenia purpura, lupus, rheumatoid arthritis, which attack the immune system, may destroy the platelets in the patients, and that can cause thrombocytopenia, which is low platelets. Other conditions like TTP, which is also called thrombocytopenia, thrombotic thrombocytopenia purpura, that is when the platelet supply runs low, which is due to blood clotting in the small vessels, and the platelet causes blood clotting as well. So that causes the platelets not to circulate properly in your body. Okay, so that is a few causes. Let's see, other causes, toxic substances, arsenic, benzene, pesticides can also cause platelet level, low platelet level, alcohol as well. Cancer patients, especially that's on chemotherapy and radiation therapy. So what happens there, that also the bone marrow gets damaged very quickly because of the chemotherapy and radiation. And due to that, the patient's bone marrow is not working properly, and they damages the stem cells in the bone marrow. So I just want to discuss also the causes when it comes to stem cell transplant patients when it comes to thrombocytopenia. Thrombocytopenia is a common complication actually in patients that have stem cell transplants, especially allogeneic transplants, because this occurs due to increased risk of GvHD. So when we talk about GvHD, it's graft versus host disease, because the donor cells that goes transfused into the recipient goes straight to the bone marrow, but it takes time for the platelets to develop. So this is when we call it impaired platelet production, is when the stem cells may not adequately differentiate into platelets because it takes a while. The bone marrow takes a while for the platelets to increase, leading to low platelet counts. Immune-mediated destruction, recipient is immune system may attack the donor platelets, causing platelet destruction. So, and other causes also viral infections. Certain viral infections post-transplant can contribute to platelet destruction. Okay. Conditioning regimes. So when the patients go in for transplant, they get a conditioning regime, which is actually the chemotherapy that they receive. And obviously chemotherapy destructs the bone marrow. So that's why the platelet reduction is affected. Okay. So how they actually diagnose and test for thrombocytopenia. So obviously they do a full blood count, they check platelets, red blood cells, and white cells. And then also they do a peripheral smear to examine the platelets under microscope. Blood clotting testing, so they do the prothrombin time is also a test that they do to check the clotting, to check the time, how long does the blood takes to clot. And then also bone marrow biopsies. They can also do bone marrow biopsy to check the platelet count. So these are all tests that they can do to check for thrombocytopenia. So I just want to give, this is just an overview, what they say, what is the normal platelet count, mild, moderate, and severe. So normal, we get 150 to 450 per per microliter, mild, moderate, and severe, which is below the 10,000 per microliter. And if they want to do platelet transfusion, they will only, our protocol, they will only do platelet transfusion if there is active bleeding, even though the platelet is below 10. So I'm not sure what is the protocol for the other hospitals. So then I can go to, can you still see the screen?
Yes.
Okay. Let me just go further down. Sorry for this. Okay. So now I'm going to give an overview for management of thrombocytopenia, leukemia, and lymphoma patients. So in leukemia and lymphoma patients, the cells, they take up space that's normally used for healthy blood cells in the bone marrow. This can lower the number of platelets. So first-line treatment for patients with thrombocytopenia, leukemia, and lymphoma is platelet transfusion for active bleeding. So when I say active bleeding, like I explained before, like for us, if a patient's platelets below 10 and they are not actively bleeding, we won't transfuse the patient with platelets. Also, if the platelets are low, we won't give chemotherapy or irradiation to our patients. So that is for our leukemia and lymphoma patients. When it comes to management and treatment of acute immunodiseases like the ITP, like I explained previously, and the TTP patients, for our outpatients, they are on steroids that boost platelet production. They get followed up monthly. If there is no improvement, the doctors will prescribe rituximab, which is an immunoglobulin that we use to improve platelet production, but the patient comes in once a week for the rituximab, and it's given over a month. So it's 4 times that they get the rituximab per month. And then also they give them polygam as well to boost their immune system. So management of thrombocytopenia in severe cases. This is for your ITPs and TTPs, and they will be treated as an inpatient. So what basically are done, they are started, plasma exchange is which we fresh frozen plasma to the patients within 4 to 8 hours of diagnosis of especially TTP until the platelets is above 150. And they also are given steroids with the flex to improve platelet production. The taximab they give probably about weekly as well to improve the platelets. And then also, when it comes to if all this fails, the patient can have a splenectomy because most of the TTP patients it's due to the fact that the spleen is tapping all the platelets and there is no circulation in the body with the platelets. So that's why they would do a splenectomy to alleviate the TTP especially. So, management of thrombocytopenia during and post stem cell transplant. So what I always say, there should be supportive care when it comes to thrombocytopenia, especially in stem cell transplant patients. There must be careful monitoring of the platelets. If the platelets is low, they should be transfused with platelets, and they should avoid invasive procedures when the platelet counts are low. The patients are put on thrombopoietin receptor antagonists. So by us, they use a thrombo bag to stimulate the platelet production. I'm not sure if this is used in, in other facilities. And um, and this is, our thrombo bag is actually used in cases where there's prolonged thrombocytopenia after transplant. Other management is your immunosuppressive therapy, because especially in allogenic transplants, the patients are on immunosuppressive drugs, to prevent bone marrow rejection. So what they are on usually is cyclosporin, tacrolimus, or MMF. And this treatment, they usually check their levels, cyclosporin levels or MMF level, tacrolimus level, when they come for their visits, just to check if the medication is at a level that it should be. Because if it's not, it can cause that the bone marrow, the engraftment of the bone marrow will not work, and the counts will be very low. Okay? And it will also give them GVHD if their cyclosporin or tacrolimus levels is not at the correct level. Next is very important, nursing interventions when it comes to thrombocytopenia or a patient that is bleeding. Very important to ask the correct questions, regular assessments or signs of bleeding, including bruising. Ask them the question, is there bruises? Is there cherry spots? Are you bleeding from the gums? Is there blood in the stool, urine, or are you vomiting blood? Vital signs are very important, especially the blood pressure will drop if the patients are bleeding. And this can be, a patient can have a brain bleed, and then the blood pressure will be perfect also to the vital signs, especially to check if the patient is bleeding. So bleeding prevention is obviously avoid invasive procedures. If the patient is bleeding, apply prolonged pressure on puncture sites after blood is drawn or injections are given to the patient. When it comes to brushing of the teeth, they should use a soft brush, and avoid electric razors actually. Um, Try and educate them to prevent strenuous activity, heavy lifting, contact sports, monitoring of internal bleeding, especially in the abdomen, and then if that they can do if the patient have abdominal pain, and abdominal ultrasound can be done on the patient. Other intervention, patient education, very important. Teach the patient to report any signs of bleeding, so they should know by now what is when there's a bruise or when there's cherry spots or they're bleeding from the gums, bleeding from the nose, that they are aware that they should be treated. When it comes to medication, they should be educated not to use aspirin, because it does impair platelet function. Encourage them to have vitamin K to support clotting. If they have a bleed at home, you need to educate them how to treat it, applying pressure. If they're in hospital, obviously they will admit. We as nurses, if the patient is bleeding, we will administer platelets according to the doctor's orders, obviously, and then we will monitor the patient for any shock if there is severe bleeding. Okay, very important as well to teach our patients when it comes to thrombocytopenia or have thrombocytopenia. Self-care is very important for our patients. They should make a healthy lifestyle changes, dental care, no smoking, um, take over-the-counter medication to reduce that or not take, because some patients they will take Bruton's um, or aspirin, which can cause bleeding. Avoid activities that can cause bruising and bleeding. Tell your healthcare providers about your medication, which means they need to provide a detailed description of what medication they have used that could have caused the bleeding. Self-examination is very important for our patients, especially if there's new bruises that appears or the chew spots. And unusual bleeding is very important to report that. So we must teach our patients to be vigilant and always do self-care. Yeah, and that's it. So in conclusion, thrombocytopenia can be a life-threatening. Treatment depends on severity. A comprehensive evaluation need to be done. Our patients need to give a thorough history of the bleeding, how long they've been bleeding, where have they been bleeding from, etc. Nursing care goals: prevent and early detection, intervene when bleeding occurs, teach our clients and families about lifestyle changing and safety precautions. Early detection, evaluation are very important, which can prevent hospitalization when it comes to thrombocytopenia or bleeding. And that's it. Thank you. Is there any questions?
Thank you, Shamimah. So I'm not sure if there's any. Yeah, so Drina Haynes has raised a hand.
Hi, sister. Thank you very much for that insightful presentation. It was really very interesting, and thank you for sharing it with us. Just to the board and everybody that's involved, do you think, will it be possible to send through the presentation that we can, present it to our girls that weren't able to attend these meetings on a Monday afternoon?
I think it will be on the, isn't there a shared link, Dr. Jatoy, for the
Yes.
presentation?
So what will happen is that it will be actually, I think it's going to be probably accessed on the Blood SA website. Yeah,
Okay.
that's how I understand
Dropbox,
it.
isn't it? Is that in Dropbox?
Yeah, it's going to be like online where you, if you go into the Blood SA website, it will be accessed there, I think. But we can also create a different platform to let everyone get access to this.
Okay. Yeah, is there any other questions?
See, Michelle Kenyon is online. I wonder if she wants to say something.
Thanks very much. I'm very sorry. I've literally just joined as I left another meeting that I wasn't able to get out of to be able to join earlier. But I can see there are loads of people online, so it's delightful to see that the first training session, the first webinar, has been so successful. So I'm very pleased to see that, and very well done for getting this off the ground. Look forward to the next ones.
Thank you, Michelle, for joining.
I'm very sorry I was so late.
No, it's fine. It's fine. Thank you.
Candace, I don't know if you wanted to make a comment or.
Yeah, me?
Yes.
No, I'm really thrilled to see the turnout today. So I really must thank Shamimah for being the first person, and already we can see the fact that you've done it and how much of an impact it's going to actually have these meetings. So I'm really thrilled, and yes, onwards and upwards.
Thank you, Candice, for joining.
Okay, any other comments or questions? Doesn't look like it. Okay, I just wanted to say one thing, Shamimah. So just when you have a bone marrow transplant patient and they're in the unit, so often they, you know, because of the chemotherapy, as you quite rightly say, that we destroy their bone marrow, so their platelet counts can drop quite low. So what the clinicians often do is when they see a platelet of about, and this now depends whether you've got a fever or infection. So we use a trigger of about 20 to transfuse platelets. And if you don't have any fever or infection and your infection markers are quite low, then we often use a trigger of 10. But it also depends on the condition of your patient. So if they don't have any bleeding condition, then we, yeah. Because often what happens is that you get a patient that even if the platelet count of 30, they might have some epistaxis, then we give them a unit of platelets. And we never order 2 units, we always order 1 at a time. And of course, depending on the transplant it is, it needs to be irradiated. So that's also important. So if it's an allogeneic transplant, so from a different donor, then irradiation is also important. But yeah, that's the only thing I wanted to add, but I think your talk was really good. And thank you so much for preparing this. It was great.
Sorry, Justin. Justin, this is Charlene. I just want one more comment about for the nurses, please, is that platelets are kept at room temperature. I need to be transfused as soon as you get them to the ward. Just that's another thing, is that it shouldn't be left lying around because platelets are not kept in fridges in the blood bank. So just that's the point I wanted to make for the nursing staff. Thank you.
Yeah, platelets actually, when it leaves the blood bank, it expires within hours. So for us, the protocol is the platelet infusion should take at least 30 minutes. So yeah, and then also when it comes to our outpatients, whose platelets are low, you see, due to financing that we don't wait. We actually, if the platelet is low and it's below 10, we are taking that, not take a risk, but if there's no active bleeding, the patient won't receive platelets. Unless there is like a sign of bruising or petechiae or the cherry spots or the gum bleeding, then we would definitely infuse the platelets. Yeah.
Okay, great. Don't know if there's any other comments. Okay, so I think that's about it. We can probably call it a day, and this is our first session, so thank you so much. And then the next time we will have a different speaker from a different country, so that's going to be exciting. And I'll work with Michelle on that. But anyway, have a good afternoon, everyone, and thank you for joining. Bye.
Thank you, Justin.
Bye.
Thank you.
Thank you.